So what's the proper utilization for this urine test called the Exosome DX test to try to avoid from getting a biopsy? Who is the right candidate? What if the number is slightly above the cutoff of 15.6? Does that require a biopsy? Does that imply prostate cancer? Today's conversation is with the one and only, the person who founded and developed the Exosome DX test, Dr. Johan Skog, who is the Chief Scientific Officer and founding scientist of Exosome Diagnostics. He has pioneered discoveries about exosomes and other microvesicles and their vital roles, both as cell messengers and disease proliferation. Tongue twister for me. Dr. Skog has a PhD in gene therapy and virology and a master's in biomedicine from, I'm going to butcher this name, in Sweden, Umeå University from Sweden. I probably butchered that name. Anything that has to do with exosomes, Dr. Skog, we call him Johan in the pod, is an expert in. And we go through it. And I try to pull out, scientists by nature are very careful with what they say. They don't commit to too many things. They don't commit to say, no, you can use it absolute. There's no absolutes. And of course, there's no absolutes in science or medicine. But sometimes we need that as clinicians. Say, hey, what's a good out of the box thinking with this test? I try to pull some out of him, and it was difficult. He's a scientist. But we had a great conversation on the development on exosomes, how it works, what it really is, what are they looking at, and its clinical application that will help men not only figure out who needs a biopsy, but actually also who needs treatment based on studies. So enjoy this amazing conversation with the one and only Dr. Johan Skog. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Now, please join me in welcoming our next sponsor. And now, I'd like to acknowledge our three amazing sponsors that you will hear about throughout this podcast. One is XY Wellness, a company I'm very familiar with as co-founder and medical director, a lifestyle company, XY Wellness, specific for men with prostate cancer. Next is Veracyte, the makers of Decipher genomic test. After a biopsy or even a prostatectomy, you want to know how your cancer may behave. This is how the genomic test Decipher can help. Third, Exosome DX. Prior to having a biopsy, you want to know if you really need one. And the Exosome DX test, a urine test, is very helpful to determine if you need a biopsy or if you don't. Thank you to today's sponsors. Welcome to the Dr. Geo Podcast. I'm your host, Dr. Geo, always willing to help you optimize your prostate health, testosterone, erections, and as men, how do we live better with age? How are we stronger, healthier with age? Today's guest is Dr. Johan Skog, Johan Skog. Sorry, Joe. You did have a Jonah in your office once, and that he introduced. So I always confuse, and I'm still confusing the name. So very sorry, but Dr. Skog, Johan Skog, and it's a treat. You know much about him from the intro. It's a treat. This is the scientist that's behind, and I'm sure there's a team, and we're going to talk about that, behind a test that I use often, the Exosome DX test. I think is a valuable test in terms of determining, who's a good candidate for a biopsy. They absolutely need a biopsy. And when you combine that with other things like, MRIs and other tools, the person typically that gets a biopsy is because they absolutely need it. So the Exosome DX test is one of those tools. Johan, thank you once again for joining me today.
Of course. Thank you for having me.
So Take us back. So, I had Dr. Eli Devincioni on, who, as a developer of Decipher, my audience knows as well. And I'm always curious to know why you guys do what you do. So why, you wanted to be a scientist, and I think you're an expert, and correct me anywhere in our conversation as needed. You're an expert in exosomes specifically, and you've written many papers on it. So out of all things to be an expert in biology, why exosomes, and what motivated you to look into this a little bit deeply?
Right. I mean, I think this relates to the fact that you can't always plan your future all the time. Sometimes things just happen. So my background is actually in virology and gene therapy. That was what I did my PhD on.
Virology and gene therapy.
Yes.
Were you busy during COVID as a result of that background?
So this dates back well before COVID.
Exactly. But I figured that since you're a virologist, I would say that during that time, you dove into COVID a little bit.
Oh, we did, yes. So basically during COVID, we found that there was a great need for COVID testing in the area, because in the beginning of the COVID pandemic, no one could get a test done. Right. So we quickly set up a COVID PCR-based test, and we offered that to the schools and other areas around Boston here. So.
Oh, beautiful. I figured that would be the case. Yeah. All right, take us back to exosomes.
Yeah, so really I was working as a postdoc here at Mass General Hospital in Boston at the time. So this dates back over 17 years now. And I was working on something completely different, basically tumor stem cells in brain cancer. My expertise was in brain cancer and gene therapy. And I made this observation that these cells that I was working with had an unusual amount of blebs around them. And upon a closer examination of these cells with something called electron microscopy, where you can really zoom into the cell level, I found that there was a huge diversity of vesicles around these cells. And at the time, we didn't really know what these were, but there was an active research field around something called exosomes back then. And their research literature stated that they do not contain RNA or nucleic acid in general. And they just had proteins, and they were considered almost like a trash vesicle of the cell that was used to remove cellular content and proteins from the cell when cells were differentiating. But at the time, I was working on profiling RNA in tumor stem cells, and I saw that these blebs or vesicles were coming off from the cells, and I realized, well, there must be a way that RNA comes into these exosomes. So I had no background in exosomes at that time, but I'm a virologist, and these small vesicles, they look very similar to a virus particle. So I employed a virus isolation protocol to isolate these from the cell, and I was lucky enough to find that they were full of RNA. And that hadn't been shown before. So I spent about 3 months trying to figure out what I did wrong. Why was there RNA in there when the literature said that there was none?
And at the time, we're talking about RNA in general, not necessarily associated with tumors or just RNA.
RNA in general. And at that time also there was another publication that came out that showed that they had also found RNA in exosomes from cell cultures. So I was more clinically sort of focused on the brain cancer and thought, well, maybe we can isolate these from biofluids such as plasma or urine. And if I can show that I can isolate mutated RNA from patients with tumors, then I've proven that these exosomes are coming from the tumor and that they're stable enough that they can be isolated from biofluids, because that would really be a new way of doing diagnostics for all kinds of things. So my focus at the time was brain cancer. So I took serum samples from brain cancer patients, glioblastoma patients, and I looked for a tumor-derived mutation called EGFRB3 at the time, and found it. And so basically showed that even after samples had been stored in biobanks for years, we could isolate the exosomes from the biofluid and find tumor-specific changes or mutations, and would therefore prove that there was tumor-derived exosomes in these biofluids and that you could use them diagnostically. So that was sort of the first application of using exosomes for tumor-specific detection, and it led to filing the patents. And we also started the company Exosome Diagnostics a year later in 2008.
2008. Okay.
Yeah. So Exosome Diagnostics was founded in 2008, and we started to develop diagnostic applications for a variety of diseases, and one of them was prostate cancer. And the choice of prostate cancer was really interesting because we had set up shop with a company in New York at the time, near the Presbyterian Hospital there, and we were working with an PI there, Dr. McKiernan, Jim McKiernan.
Yeah,
and
that's right.
He was very interested in utilizing this technology for prostate cancer. He knew that RNA from urine exosomes was really going to be a game changer, because you can monitor so many different things on the RNA, and if we can harvest RNA from a urine sample, that would be a big deal.
So we're talking 2008.
So this was a few years later. We'd actually come a little bit further in our programs at this time. I think this was back in 2010, 2011.
So that was a time to bring context into that period of time as it relates to prostate cancer. That was a time where PSA was the main way of determining, and it was still the Wild West in terms of, PSA's high biopsy and overtreatment on cancers that don't need to be treated, and overdiagnosis of prostate cancer. And later on, a few years later, 2012, is when the United States Preventative Task Force says we're overutilizing PSA and it shouldn't be used as a diagnostic. So the timing could not be any better. When McKiernan, who I know well, I worked with him, he wrote actually one of the first papers as a PI in a major journal about exosomes and this urine test. We were all like, wow, what's going on here? I was there. Actually, I had just left to NYU because I trained at Columbia for a little bit of time with McKiernan. But I heard some talk while I was there about such a interest in this urine test. Like, urine test, right?
No, I mean, it was really a good timing and a game changer, because we'd shown that from a urine sample you could harvest RNA, and we've proven that it came from the prostate because we could find markers such as the TMPRSS2-ERG fusion that happens in about half of prostate cancers. We could detect PCA3, which is a very important prostate cancer marker.
Was PCA3, so that used to be a test that we use clinically. Was that, I can't remember if that test was already around in 2010. I know that was the primary test. And then what we noticed was that PCA3 by itself, as a clinician, it was still not good enough. We were looking at indolent Gleason 6 cancers were coming up with PCA3 at the time.
Correct, yes. So what we did at the time was basically to continue the development of the signature, because as you mentioned at the time, the goal was to better stratify patients and make sure we don't do too much over treatment of indolent cancer.
Right.
And there was this need of making sure that you did not have clinically significant prostate cancer. At the time, there was a sort of Gleason 7 and higher was considered the cancer that you need to detect.
Right.
And Gleason 6 and benign processes shouldn't even get a biopsy. So at that time, we basically tried to find a signature that could differentiate between these. And like you mentioned, PCA3 alone and TMPRSS2-ERG alone would not do a good enough job for that. So we continued the marker development and came up with a signature, a 3-gene signature algorithm that worked well to rule out significant prostate cancer. And that was developed during these years, and the final validation of the signature and the cut point was published in 2016. So this was now 8 years or 9 years after the discovery of the exosomal RNA and the start of the company. We had now a validated product on the market. So I think that the time it took to develop this was very quick when it comes to from discovery to commercial application compared to many
I
other.
think so relative to others, because it just usually takes a long time. I always joke around, Johan, saying that there are two things that teaches you patience: children and science, and and the application of that science.
Yes, absolutely.
As a father of 3 and a scientist, I think you would agree.
Yeah.
You're probably the most patient person I know.
Well, you got to have grit.
Patience and grit. Patience and grit.
Yes. Yeah. No. So that was basically the story. So the commercialization happened in 2016 of the ExoDX prostate or EPI test, and we've continued to publish and present sort of the clinical utility of this test over the years. So in 2016, when we published this validation study, we immediately started with a second validation paper, basically to show again that if you do this at a different time and at different institutions, you get the same result. Right. And the second validation just was perfectly aligned with the first one.
Excellent. But the second validation study was done where? That one I'm unfamiliar with.
Yeah, so it's also done in US. It was published in a European Euro. The first validation was published in JAMA Oncology.
That's right.
And the second validation, European Urology.
And what institution? Or is it multiple institutions?
Oh, multiple. We did 4, I believe, different institutions across the US with a very diverse population. Yeah. We had somewhere between 13 and 18% African American contributions, and other ethnicities included as well. So a very diverse population that is well representing the US population.
JAMA Oncology, the first one, the second one, European Journal of Urology. Was that? These are two, one of the two most prestigious journals to publish in. So yeah, that caught many people's attention for sure.
Yeah, for sure. And I think we've done some very novel studies as well after that's proven the utility of this test, because there's one thing to validate the test and show that it actually performs really well. Then after that, you want to see that when you let the test out in the wild, so to speak, when people are using it, how does it affect the outcome?
Today's discussion is also brought to you by the makers of the Exo DX test. The Exo DX prostate score is a non-invasive, no DRE necessary, so no finger up, no prostate exam necessary, urine test to determine if you need a biopsy. Now, we all know the issues with the PSA test. It is a great test in my clinical opinion, but is imperfect. So what else is out there to determine, you know what, I really need a biopsy? Unfortunately, there's no other way around it. That test is the Exo DX test. Again, a urine test, pee in a cup, send it to a lab. It gives you a score. If the score is above 15.6, you likely need a biopsy. If it's below 15.6, you may not. So this urine test, the Exo DX test, should be part of the decision-making, part of the shared decision-making between you and your clinician on whether or not you need a biopsy. To learn more about the Exo DX test, please visit the link below in our show notes.
How does it affect care? And does it provide better care? And to really evaluate that, we did something novel that I haven't seen other tests in this space do. And that is a prospective, and we had a blinded control arm in
right.
that utility, and that's the unique aspect that utility study.
I mean, you do have
the utility of it.
100%. You do have competitors, but I have to say that the robustness of the research that you have done and the focus on in the long game that you've done, you and your company and your peers and team members, has been extraordinary and really high quality. I mean, at this point, I would say it's the number one biomarker that most of my colleagues use. Is easy.
Yeah.
First of all, when it there are times where, look, the test, we've done this testing and we've studied it and it shows that it's good. All right. How easy and feasible it is for a clinician that matters. There are times where the studies are good, the research is good, but it's not feasible for the clinician. So things take a little bit longer. And sometimes clinicians just don't do it despite the research. So the name of the game is research showing, a good outcome, the outcome that we're looking for. And number two is how easy. Exosome DX, I have to say, is really drop ship, pee in a cup, send it back, and you get a number back.
Yeah, I think this is one of the strong advantages where you can get the molecular content, so this molecular RNA signatures out of the exosomes from a simple urine sample.
Yeah.
It doesn't require a DRE or anything like that. So we have this urine collection kit that can be done in the office with a urologist's office or shipped home to the patient. So that basically empowers them to donate the sample anytime and ship it to us.
Let me ask. I'm sorry. Go ahead.
Yeah, and once the sample arrives at the Exosome Diagnostics CLIA lab, we accession the sample. We do all of the QC checks of the sample. We isolate the exosomes, extract the RNA, and then we do analysis of these three genes, PCA3, SPDF, and ERG, and that goes into an algorithm and gives you a score from 0 to 100, where the higher the score is, the higher your chance is to find high-grade prostate cancer upon a biopsy. So that's really where the utility falls, where if you have a score that's below our validated cut point of 15.6, then it's a rule-out test, right? So if you're below the cut point, the test has a 91% sensitivity and over 90% negative predictive value. So very efficient on ruling out high-grade prostate cancer. I think the negative predictive value is up to 97% if you classify 4+3 Gleason and higher as the clinically significant one.
So the cutoff of 15.6, if it's higher, it is suggesting 4+3 or 3+4 or just Gleason 7 period?
Gleason 7.
Yeah.
Gleason 7. So if you have a score of 30, you have a roughly 30% chance of finding high-grade prostate cancer upon a biopsy, and at a score of 50, you have about 50% chance of finding high-grade prostate cancer.
Johan, let me ask you a question. As a clinician, if I have a patient who, so most of my patients, and I think most people listening to this podcast are saying, I don't want a biopsy unless I absolutely need one, right?
Yeah.
So it's invasive. It could potentially comes with complications and so forth. So I do an Exo DX test and it comes back 17, let's say. How tight are those numbers that, and let's just say that this is the only tool I have here. I know we could do an MRI and other things, but just for our conversation, it's 17. PSA is stable. There's no increased velocity in PSA. Nothing else, DRE is good. No nodules. 17, not 15.6. Just a point and a third, 1.3 value up than 15.6, 1.4. How tight is that 15.6 number?
Yeah. So the 15.6 is drawn as a cut point that was validated. And when you're below 15.6, you have 91% negative predictive value, right? So very low risk of finding high grades below there. And as you start to incrementally go higher with the score, you increase your risk of finding high-grade prostate cancer. So to give you an example, if a man over the age of 50 with a PSA in the gray zone between 2 to 10, and this is sort of the indicated use for the test, if a man comes into a urologist in that range and goes through with a biopsy, today, typically they find high-grade cancer in 30% of those men.
Mm-hmm.
That's kind of the hit rate right now in modern cohorts. So if you have a score of 20, you still have a lower risk than when you walk through the door. You're positive because you have about 20% chance of finding high-grade prostate cancer. So it's really, now it starts to be sort of a discussion with a patient of risk tolerance, right? Where you are at a lower risk than the average man in that risk group that comes in. Mm-hmm. The story becomes very different when the score is 40 or 50, because then you have a 40 or 50% chance of finding high-grade prostate cancer in a biopsy. And that may be too much risk. And we know, since the hit rate is 30% in a patient population between 2 to 10, PSA of 2 to 10, we know that is the average risk of a man that receives a biopsy today in that PSA gray zone. So that's where the utility of the test comes in. And I like to speak a little bit about that because I think it's an important factor. So the scientific study that we did that looks at the utility of the test, we had 24 different urologists that were part of the study. And all men that came to see them received a urine test, right? Or all men in that PSA gray zone between 2 to 10 received that test.
And these are men who had a PSA between 2 and 10.
2 and 10 and over the age of 50. So they were coming in for evaluation of, should I do a biopsy or not? And we withheld the data from half of them. So it was randomized. So half of the samples, we sent back the score, the EPI score. And for the half of them, we blinded them so that basically the doctor wouldn't see that test result. And we said, now you have to make the decision with standard of care. Basically, go ahead and make your decision with whatever tools you have available. And they can use any tool, any other biomarker.
Whatever it was at that time, which is back then, it was still, I mean, not even the MRI was that sophisticated. And they didn't do targeted biopsy. So it's high PSA. We have to do a biopsy and then get treated accordingly.
Yeah. What we found was that doctors that received the EPI test back found 30% more high-grade prostate cancers than the doctors that were blinded to the result. So that was really fascinating to us. We didn't expect that to happen because we didn't design the test as a rule-in test. We designed it as a rule-out test. But just the doctors knowing that, okay, now I have a high-risk patient in front of me, that made their decision much more precise. So that the men that were at real high risk for prostate cancer received the biopsy and went through with it. And the men who had very low risk could safely defer the biopsy. And what was really interesting was that in the control arm, the doctors who did not receive the test score back, we looked at them, that the patients who had a high score and a low score received the same amount of biopsies. Mm-hmm. So the standard of care parameters that the doctor had in front of them were not able to differentiate the high risk and the low risk patients with other means. Mm-hmm. So if we didn't deliver the test result back, they would over biopsy the low risk patients and under biopsy the high risk patients, right? So they had exactly the same biopsy rate. Whereas in the epi arm, the doctors who received the test back, they biopsied the right men. And therefore they found 30% more high grades than the control arm. And we saw that in the epi negative group, they actually received fewer biopsies so that they could say they were safely deferring their biopsies.
So that means that in kind of lay terms that this study showed not only did it show which was what the company and you were focused on, hey, let's figure out who doesn't need a biopsy.
Yes.
As a secondary outcome that sort of you were not really looking at, it showed, wait a minute, not only can we show who needs a biopsy, we can actually show, or who doesn't need a biopsy, we can actually show who needs a biopsy based on and who would benefit from a biopsy because it's going to be a higher, grade and it needs to be treated.
Yes. Yeah, because at the time, we realized that there was a lot of hesitation among patients and in their shared decision making, their doctor, that a slightly elevated PSA may not be so bad.
Yeah.
And a lot of men prefer not to have a biopsy. And in their shared decision making with their urologist, they decided to not have a biopsy. And without the use of the EPI test, many of the wrong ones that were truly high risk deferred their biopsy, and they actually were missed in the control arm. So that was a really interesting finding that we discovered at that time. And we followed these patients over time. And now we've done a 2.5-year follow-up and even a 5-year follow-up. And the benefits of even that single urine test done many years ago still affects the outcome for up to 5 years later. We have still more high-grade prostate cancers detected, and the low-risk patients safely deferred their biopsies.
Yeah, that's a win-win for sure. Why the PSA range of 2 to 10 to order and not 15 or not 1.8? And I ask you this because I see many patients that have a PSA of 12, 15, even 20 without prostate cancer. You just have a big prostate. And I should say that I do order the test myself in patients with a PSA above 10. Am I wasting my time? Am I doing the wrong thing? Why 2 to 10?
That's a great question. And so both the cut point of the test and the intended use of the test was decided through an external advisory board that we put together early in the phase of the company, where we had over a dozen key opinion leaders in this space that were well knowledgeable about the diagnostics of prostate cancer. So mostly urologists, but also statisticians that sat together and they looked at our data and decided where the cut point should be, as well as what the intended use should be. So the 2 to 10 range was decided because that is where most urologists would need a second opinion. If you have a PSA of 20 or 50, most urologists would just go ahead with a biopsy, and a rule-out test in that scenario wouldn't be as clinically useful. In our JAMA oncology validation study, we included men from PSA 2 up to 20, actually. So we looked at the whole range up to 20, even though we had a predetermined range of 2 to 10, that was the intended use of the test. We also looked at the performance up to 20, and we had an equal performance up to PSA of 20. But at the time, we thought that fewer doctors would actually use the test in that upper range, because when you have higher PSA values, they're more inclined to just go ahead with the biopsy. And that was the rationale for it. But I invite everyone that wants to read the JAMA Oncology paper to see the data up to 20. They would see that the performance is the same.
What was the positive predictive value? You don't have to be exactly perfect with your response, but in men with a PSA above 10, what was the positive predictive value with the exo test?
The cut point of 15.6 is for the negative predictive value.
Right, okay.
So the PPV, or the positive predictive value, depends on the score.
Yeah.
So at a higher EPI score, you have a higher PPV. So basically, at a score of 30, you have a 30%, and a 50 is 50%.
So let me rephrase that question. In men in that first 2016 study who had a higher PSA than 10, they also did an Exosome DX test. How many men, what's the percentage of men who, in other words, I'm trying to figure out, is there value? And I personally think there is based on my clinical experience, but it would be great if the scientific research supports my clinical experience. Is there value in men above with a PSA above 10 using an exo test? What did they look at those men with a PSA above 10 to show, yep, there's a certain percentage that do come up positive, or a certain percentage that still comes up below a 15.6?
Yeah. So because the validation documents were written in that way, that we wanted to look at 2 to 10 primarily, that's where the intended use is and what I can personally recommend.
Right.
As a doctor, you can read the article and look at the data up to PSA of 20 and just look at the data and review it and make your call on how to treat those. So I want to be a little bit mindful of how we wrote the validation documents, that our intended use is 2 to 10. But everyone should feel free to review the data that was published.
Yeah, you're being a scientist and very careful with what you say.
Yeah.
It's almost like every conclusion on every paper, we need further studies. So scientists cannot commit to anything, right?
That's because everyone. So you can make informed decisions of best, like what makes sense.
Yeah.
But as a scientist, you need to have that data backed up with a study.
Yeah.
So,
right. And even after a study, there's still a conclusion that says further studies are required to validate the outcomes of something along those lines, which is like, man, that's part of the frustration with the lay people. It's like, just tell me what to do. They need an answer. Scientists are the opposite. It's like, well, maybe this, maybe that, based on the study shows this. It doesn't.
Yes. Well, as a scientist, you're supposed to be a purist when it comes to the data, and you like to stay with it.
Which is the challenge for clinicians, because we're in the middle of you guys. So we're we're in the middle. We're with the patients and we're with you guys, and we're in the trenches, trying to make decisions, the best decisions we can for our patients.
Yes.
So is there a chance that I'm very interested in this 10 to 20 PSA element of the practice? Is it, because again, there's just I think there's a good number of men that have a PSA between 10 and 20 who don't have prostate cancer. They just have an enlarged prostate. Is there, you think, is down the pipeline, is there any interest in looking at this? Are you looking at it now to see if there's any validation studies in that group?
Right now, we're not doing independent validation in the 10 to 20 range, but we do have the historical data from the initial validation. So we know pretty much what the performance is there. So you can always look at the JAMA Oncology publication and see.
Yeah, we'll tag it to PubMed, but it doesn't only comes with the abstract. So I guess people will have to purchase it if you're not part of an academic institution, unfortunately. But it's probably out there. I may write something up about it. What are the chances? And again, scientists struggle with saying things that are not completely validated or proven by research. But in my world, I'm like, it's okay. Tell me your thinking and your guesses, because God, you've been doing this for so long. You have a much better guess than I do. What are the chances of that 15.6 cutoff to either go higher? Say, hey, you know what? We did more research and now it's 20.6. So if it's above 20.6 is a higher risk, or lower, tighten it up a little bit. Hey, nope, it's now 10.4. What are the chances of that happening?
Well, excellent question, right? So we've done studies that and shown that 15.6 is actually a cut point that gives you that same negative predictive value every time. And we did have, in our key opinion leader group, we had urologists that said maybe the cut point should be 20. And you can read about this discussion actually in the JAMA Oncology paper, because we do present data at a cut point of 15.6 as well as 20 for that reason. Because there were some urologists that were more okay with more slightly more risk, right? So the risk at a score of 20 versus 15.6 it's a tiny bit higher risk at 20, but you may have more benefit because you have more men now that are negative and you can rule out an unnecessary biopsy. And I think it depends on urology. Some urologists think that, well, I'd rather have more men avoid an unnecessary biopsy. If most prostate cancer is fairly slow growing, and I'm going to see them again next year,
Yeah.
and rather have that cut point at 20. That's why in the validation study we present the data at both cut points, but our internal recommendation has been 15.6.
Yeah, as a clinician, and most patients who come see me, they're very conservative. They want only natural things if possible. They want to not get a biopsy if possible. And so when
Yeah.
they see me, I have to kind of help them navigate with that decision. And when the EPI score comes back at between 15 and 20, it really depends on the MRI and their PSA velocity, PSA density, in my opinion. If the MRI
Yeah.
has a PIRAT of even 2, let's say,
Yeah.
and PSA velocity is good and their PSA density is, less than 0.1, I say, look, this is ultimately your decision, but it's very unlikely, not that you don't have prostate cancer, because after a certain age, we may all have it if we live long enough, but
Yes.
it's maybe something so indolent that it's not even worth finding. So what's
Correct.
your risk tolerance here, right? That's kind
Yeah.
of some guys are like, oh, they're numbers oriented. No, my PSA went literally, Johan, I'm not kidding. I get guys like if their PSA goes from 1.2 to 1.5, they're going crazy. I mean, they're going
Yeah.
absolutely crazy. So PSA, and we call it patient stimulated anxiety for a reason,
Yeah. Yes.
right? This is why, and then I did by the way, this is actually a real case. This is actually a real case. It's not even an example. Patient, PSA went from 1.2 to 1.5. Oh my God, no, my God, are you sure? His PSA percentage, free percentage, was at around 25, 20, 26, which the higher it is for the audience, the better it is. He said, but I read somewhere that if it's, above 20%, that is bad. So 25 is, so he got into a rabbit hole. All right, let's do an exo test. Exo test came out about 14. What do you think he was happy with that 14? No, it's way too close to 15.6. So I sent him the results of the test saying, hey, good news. Exo DX, Exo score came back less than 15.6. You would think that he would say, "God, congrats, thank God," right? No.
Yeah.
But it's too close to 15.6. Am I in
Yeah.
trouble? Am I gonna do I have prostate cancer? So all that to say for the audience listening that, and it's okay by me, but I understand that this whole process is highly psychological as well, not only physiological, is emotional. Maybe you had your dad die from prostate cancer, all these things.
Right.
Speaking
Right.
of, so then that triggers, PSA triggers a response, but keep that
Yeah.
in mind that you don't want to be overly diagnosed and certainly overtreated. And that's a thing that, honestly, everybody's trying to fix, including urologists. You would think that they're not trying to fix that because, that's how they make their income. Not the case at all. They want to treat only prostate cancer that is worth treating. Today's discussion is brought to you by yet another amazing sponsor, Veracyte, the provider of the Decipher Prostate Genomic Classifier. Here's the deal, folks. After a prostate cancer diagnosis, what you want to know is, how is my cancer different than any other? The Decipher test helps personalize the diagnosis a little bit better so that one knows how aggressive their cancer is, because we all know that not every prostate cancer is created equal. I clinically use the Decipher test almost every day, as it helps me determine how is this particular patient in my office, prostate cancer, different than the guy I saw earlier today or different than the guy I saw last week. How is their particular tumor behaving differently or will behave differently? That approach helps with the shared decision making between you and your clinician as to what's next for me. What is the best approach? To learn more about the Decipher test, please visit the link below in our show notes. Same thing with my end with natural methods. I want a good, healthy approach prescribed, like people that practice like I practice is very good. You can possibly even prevent it. But all that to say is that, keep in mind that, PSA at the end of the day, for the most part, is only a number, and it's one tool, one of the things we look at. And this is why this test, the exo urine test, is non-invasive and it's so valuable.
Yeah, and I think that's when you're making this shared decision with your urologist and your sort of risk tolerance for prostate cancer, it's always better to have more information. And like we showed in the utility study, without the molecular data that we provide with the ExoDx prostate test, the urologist and the patient is unable to separate the patients that have a higher risk versus the lower risk that the EPI test identifies. And I think that's a big sort of revelation, that there's nothing else with the standard of care factors that the doctor has available that will be able to give you that stratification. So we like to see that now with the additional information, more of the right men go forward with the biopsy, and the right men that have a very low risk defer their biopsies. And we see now 5 years out, there's the low risk men were truly low risk, and the high risk men were truly high risk. And even with standard of care factors over years, you're not able to find those high risk patients if you don't have access to the EPI test.
Johan, another application to the test that is not validated, I'm not holding you to anything, so don't worry, but I find potentially useful is the following. 42-year-old male comes in with a PSA of 1.5. A PSA higher than 1 in a 42-year-old male is actually high-ish, right? It's not you need a biopsy, but yeah, it should be below 1.0. B, his father died of prostate cancer at the age of 69. I want, if nothing else, a baseline exo test. Again, below 2. I want at minimum a baseline exo test to say, so for us to have something to look back to, considering that A, his PSA is relatively high for his age, and B, his father died from prostate cancer. Am I wrong?
Yeah, so like you said, the validation cohort included men 50 years and older. And what's hard to understand sometimes is depending on the patient population that you have in a cohort, the baseline risk is different, right? So for prostate cancer, the older you get, the higher your baseline risk of it is. Like if you look at men that are 80-year-olds, right? Most of them will have prostate cancer, some form of prostate cancer, but it'll be most likely an indolent cancer. So there is a need, we're seeing that there's a need to also look at patients that are younger, maybe that are 40, 42. So we are starting to look at studies where we're including men over the age of 40. And then we can say more scientifically what your exact risk is, right? So
in other words, you're not saying that I'm wrong. You're not saying that I'm right.
I'm not, because scientifically you need to do the study for it to because the younger you are, the lower your baseline risk becomes.
But that's not what we see clinically. Look, yes, of course, the younger you are, the less likelihood of you having not only prostate cancer, but any prostate cancer. Do you know how many men between the age of 40 and 47 we see with not only prostate cancer, aggressive prostate cancer?
Yes.
That's a good number. So in my mind, even though that percentage, when you look at it from a larger population, is smaller, it's still an individual that has, in the prime of his life, a diagnosis with aggressive prostate cancer. As a clinician, I don't want to drop the ball on anybody. I want to try and hit 1,000 every single time. I know I can't, but I want to try.
I agree with you that the clinical utility would be also to look in men in that range. Especially since the men that are in their low 40s that come to see you may have a higher anxiety because they're coming to see you because of a family history or because of the fact that they may be in a high risk group,
Yeah.
right? So the men that are truly 40 and sees medical evaluation may already be selected to be at a higher risk.
100%. This is not the case, by the way, where the father was diagnosed with prostate cancer at 72 and still alive and well.
Exactly.
That's not a higher risk.
Exactly.
The father died from prostate cancer at 69. To me, that all those offsprings, I want to get them going with things right away, and so that we, so that they don't succumb to this disease eventually.
Yes. So there's nothing in the test. So we look at SPDF, PCA3, and ERG. We don't have any scientific data indicating that age would change the signature for those. So I'm more thinking that the baseline risk needs to be baked in, and we need to do the study where we understand if the 40-year-olds have a shifted baseline risk of high-grade prostate cancer, or the 40-year-olds that come in to see medical evaluation for prostate cancer, where they are in that risk score. So that's why we want to do those studies, so we can give a scientifically based recommendation on the risk factors for that age population.
I think an alternative to that is, because we in other words, we can't wait that long. We have patients coming in. Your company hires a database manager for Dr. Geo Espinosa, and we collect the data and put it all in after we have 100 patients that are 40 years old with exos and follow up. We have some information to report, even though it's not an official study. I propose that idea to you.
Yeah, we're a scientifically driven company, and we're open to all kinds of novel collaborations that could drive utility and understand the utility.
You guys are so, just like Eli, so careful with what you say. God, it is and I appreciate that. I really do. Another question is the following. So let me break this down for the audience who's listening, and you tell me if I got it wrong or if I got some of it wrong. The way I see exosomes, these are like vehicles. These are like, like a taxi or a boat that, you bring. If you want to get to point A to point B, and, there's no other way of transportation, I'm going to get in this taxi, I'm going to get there. And so then it carries these vehicles. These are like bubbles. At least that's how I remember reading it, back in the day. Of course, nothing looks like those images in textbooks. But let's just say these are like bubbles that carries things in them from point A to point B. What we're looking at is what you're looked at is RNA. Why RNA? Because tumors shed both actually DNA and RNA. And so the method of finding to see if there's a tumor that is non-invasive is through these vehicles, through your urine, and then you go in, you pull the RNA out, and you say, yep, that's prostate cancer. That's, something to look at based on your algorithms. Yeah. So is that more or less?
That's correct. So tumors actually release exosomes with a purpose. So tumors release exosomes to stimulate growth of the tumor and to blunt the immune response. So tumor exosomes are actually very immunosuppressive. And based on the content, they have immunosuppressive proteins as well as RNA targets in there. So we are basically harvesting them, and we're eavesdropping on molecular signals that's happening inside the tumor, right? So right now we're eavesdropping and listening in. What are the levels of these 3 genes that are part of the ExoDx prostate epi test? We have development of future algorithms where now we can actually survey the entire RNA transcriptome. So we can look at over 30,000 RNA targets from a simple urine sample. And that's also going to be able to tell us much more about the biology of the tumor and understand the molecular things that are happening inside the tumor in real time. So I think we're gonna continue to use exosomes as a novel biomarker and game changer for the field.
Our next amazing sponsor is XY Wellness, a company I know a little bit about as co-founder and medical director of the company. XY Wellness is a company to help men renew, rebuild, and reclaim their health, their bodies after a prostate cancer diagnosis. XY Wellness is a lifestyle company that helps provide a no-nonsense roadmap to health and wellness in men after they are diagnosed with prostate cancer. The hope with our program and what we see with many of our members is that men after prostate cancer tend to thrive, not only survive, through our program. To learn more about XY Wellness and its roadmap, please visit the link below in the show notes. The prognosticator.
Exactly.
Mm-hmm.
So that's what the intent is here. So the 3-gene signature that's part of the epi is very well validated with a clinical utility, and we're going to add to that in future versions of the test.
Why would there be, and there is, because I've seen it, and this is human, this is nature, and even if it's scientific, where there's false negatives, so, or false positives. So the score is 30 and they got a biopsy and nothing, and then you're thinking, well, did we miss something? But the MRI also doesn't show, right? So that happens. Just like there's still a 9% chance of you going below a 15.6 and still having something. Why? Maybe with time you're going to find other molecules in there that, what we missed before was this other molecule along with the PCA3 and everything else that helps us be more specific.
That's what I personally believe we're going to find, that once we look at more coverage over the 3 genes are very specific to the high-grade prostate cancer, but it doesn't tell you everything. And being able to survey other markers as well might be helpful in that scenario. But I want to emphasize that there's nothing in life is perfect. Yeah. When you go in and you do your biopsy, we've seen in studies such as the PROMISE trial that was published that even when you do a 12-core TRUST biopsy, you miss 50% of the high-grade prostate cancers. Yeah. And that's something that you have to take into consideration. Yeah. And we've seen many cases when you have a high epi test that on a repeat biopsy, you'll actually find something. Right. But that being said, no test is ever perfect. And that's why we continue to drive well-powered scientific studies to advance the field and not only be helpful to diagnose high-grade prostate cancer as defined today with Gleason, but now we're able to add molecular information that could maybe tell you more about the outcome for those. As you know, even high-grade prostate cancer, many of them do not progress.
Correct.
Fall into that indolent category.
I've had many of those discussions, Johan, with Ashley Ross, Todd Morgan, many others on Eric Klein. This notion of histology versus biology.
Correct.
Right? So histology tells you Gleason score. It looks like this, and relative to the way it looks to normal tissue, you give it a grade, and that grade predicts that it will behave as something, but it's only a prediction, as opposed to looking at biology, the biology of the tumor itself.
Biology, and look at sort of the content and really understand what's going on. So I'm very excited about the future of the field as well and where we're moving this.
Yeah, so am I. Johan, final thoughts. I mean, I think we covered quite a bit here, and even I have more clarity, though I know the test, but this is why I like having this podcast, because I get to talk to people like you, experts like you, which is not always easy to get you guys on the schedule, but I think with enough persistence, it happens. So I really appreciate you spending the time with me here and spreading the word on the history of this test, which is so valuable, and its utilization. I wish you were a little bit more clinical and than careful with your suggestions, but I'll take more of the risk. I'll be more risky and do more out of the box thinking as it relates to the exo test. Final words from you, and where can people find more, learn more about the Exosome DX test?
Absolutely. So you can always reach out and look at our website, Exosome Diagnostics. And so if you search that in any search engines, you'll find the information you can read there. You can also contact our team, and we'll make sure that any questions that you have will be answered.
And there's probably a directory on the website that if you put in your zip code, it tells you what doctors are ordering this test. Is that right?
Yeah. Yes, that is correct.
All right. Johan, thank you so much. I really appreciate your time, your knowledge, expertise, and wisdom on this journey on how do we do better in this prostate cancer journey. So thank you so much.
And I think that's why I'm so excited about the Exosome platform, but because it really takes us into the molecular era, right? Where the Gleason has been very helpful up until now, right? It's very helpful in classifying low
Even
risk
PSA has, although PSA has been, frowned upon, but it has.
But it's based on what things look like. It's basically, it was invented at a time where we were still using a Rolodex, right? And now I think with the molecular content that we find in the exosomes, we can move the field into the 21st century where we're actually using modern. Absolutely. Thank you so much for having me. It was a lot of fun.
Thank you. Dr. Johan Skog. Guys, I hope you found this helpful. I'm sure you did. At minimum, if you are the patient, you're able to have a better conversation with your physician, your urologist, as to what do I do? Can you order this for me? Listen, still, many physicians are not ordering this test, which I keep telling everyone is that this test is underutilized. It's very important, particularly if you're looking to, avoid a biopsy or, everyone is looking to avoid a biopsy if they can. So hope this was useful for you in terms of learning what this test is about and how it can help. And also our conversation with Dr. David Albala from upstate New York, who is a clinician that uses this test all the time. So thank you for tuning in. Continue watching, continue clicking, continue commenting, and subscribing to our YouTube channel or whatever other platform you listen to this podcast. Thank you so much. Much love. And I'll talk to you next time. Dr. Geo signing off. Tuning in to this week's episode of the Dr. Geo Podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinosa ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com.